Good afternoon, everyone. I'm Chris O'Connor, the editor-in-chief of JACC Heart Failure, and I'm excited to be here with you to discuss our monthly JACC Heart Failure Virtual Journal Club. This international journal club features some of the best papers that are published in the journal, and we're very excited today to be talking about a paper that comes from the Victoria trial looking at natriuretic peptides and outcomes, NT-proBNP and outcomes. And we're very pleased to have the authors of this important paper, who are also the senior leaders of the Victoria trial leadership. First, I'd like to introduce Dr. Paul Armstrong, Distinguished Professor of Medicine of the University of Alberta and the founding director of the Vigor Center. And he's joined by his very close colleague, Dr. Justin Ezekowitz, who is co-director of the Vigor Center and professor of medicine, University of Alberta. We also have Dr. Jonathan Cunningham, who wrote the editorial to this paper, assistant professor of medicine at Harvard. And we have our distinguished associate editors and an audience that we will encourage participation through the chat room. So let's have a brief introduction about the journal, and then we'll get on with the topic of today. Next slide. Here's our agenda, and we'll try to adjourn by 12:45. Next slide. And JACC Heart Failure 2020. Next slide. I'm really pleased that we have a number of our associate editors. We have Dr. Fuzat, the executive editor, on today, and Maria Rosa Constanzo, Dr. Joe Rogers, Joanne Lindenfeld will be joining, Dr. Barry Greenberg has joined, and I know others of the team will be joining shortly. Next slide. JACC Heart Failure focuses on important clinical topics in heart failure, and this is a list of those topics really by rank that are the most popular with our authors and with our audience. And as you can see at the top, pharmacology and how new therapies influence the care of our patients is very important, and that's really will be an important part of the discussion today. Next slide. The journal engages in a number of innovative initiatives. We have a focus area of trying to bring back clinical trials that have perhaps been negative or neutral and never published. We offer an opportunity to publish those with editorial review in what we call our dead letter office. We're also very proud that we listen to our patients. We have patients' perspectives, and we have a number of special issues that have been very popular with our readership. Upcoming will be and already available shortly will be our mini focus on cardiogenic shock. Next slide. Today's featured article and terminal NP and clinical outcomes in the Victoria trial will be presented by Dr. Justin Ezekowitz, and the principal investigator, Dr. Paul Armstrong, will provide important commentary. Next slide. And this is really one of the important findings from the overall Victoria study that was published in the spring in the New England Journal of Medicine. Next slide. And so, Justin, take it away.
So thanks, Dr. O'Connor. Really appreciate the opportunity here to get published in a journal that we love to read, and also have a chance to also discuss it further along with the editorialists who really helped show some of the good and the interesting areas of our publication. So let's go to the next slide. And just by way of background, we're also presenting on behalf of the Victoria co-authors who you saw that masthead. And importantly, is a very large collaboration. When the Victoria trial was published, the subgroups were seen as below. Now, Victoria overall had shown a reduction in the primary outcome of cardiovascular death and heart failure hospitalization, but there was an NT-proBNP interaction across the quartiles, with the highest quartile looking to be the outlier there. So we wanted to understand this a little bit better after we saw this interaction p-value that was quite significant at 0.001, signifying that perhaps there was something going on. So if we go to the next slide, what we decided to do was explore this relationship of NT-proBNP as a continuous variable at randomization with the treatment effect of vericiguat compared to placebo in the Victoria trial, and then additionally take a lot more of the information and describe and adjust for baseline factors that would really modify a relationship between NT-proBNP and clinical outcomes, and then subsequently the treatment effect of vericiguat compared to placebo. If we go to the next slide, just as a reminder for those who have perhaps forgotten in the last 7.5 months, the Victoria trial, it was a trial of 5,050 patients with HFrEF, with an ejection fraction less than 45%, NYHA class 2 through 4, and a recent heart failure hospitalization in the last 6 months, or a couple of other ways to get into the trial. But definitely worsening heart failure. The natriuretic peptides to get into the trial are seen as below, and you'll notice they're slightly higher than some of the more recent outpatient trials in the SGLT2 era. The primary outcome was cardiovascular death or heart failure hospitalization. And the NT-proBNP was measured at randomization in a core lab, and we had a remarkable compliance with getting that information. So we only had to exclude 245 patients without an NT-proBNP value at baseline. So let's go to the next slide. When we looked at the way we were going to have to examine this, we did a number of different things, and you'll see these numbers coming up at the top 4,000 and 8,000. And as a reminder, those are not the quartiles that were initially described as pre-specified, but a data-driven cut points that we explored using a number of different techniques to identify what was the relationship of NT-proBNP and clinical outcomes. And these are the data-derived cut points. When we looked at the baseline characteristics by these data-derived cut points of 4,000, 4,000, 8,000, and 8,000, there were some differences that we noted in terms of the characteristics of the patients. You can see that the patients with the lowest NT-proBNP had a slightly higher ejection fraction, more patients in class 2 than 3. And of course, when we looked at atrial fibrillation and eGFR, there were differences. But most importantly, the MAGIC risk score was the lowest in the low NT-proBNP and the highest in the high NT-proBNP, and that probably comes into play after you'll see the next couple of slides. So let's go to the next slide. Now, this is the main result of the entire publication, with a couple of other key things coming after this. Let me walk you through this figure. First of all, on the x-axis, you'll see all the NT-proBNP values, and you'll notice that there is an extremely high number of patients across the spectrum, looking all the way out to, in fact, 175,000 picograms per mil, but we truncated this at the 99th percentile, just above 32,000. But you can also see that the 4,000 is a data-derived cut point. That's the vertical dotted line. And this is looking at the treatment effect using restricted cubic splines and a log-transformed NT-proBNP, such that the treatment effect below the 1.0 line, that's showing that vericiguat was better than placebo, and above is placebo better than vericiguat, with the blue shaded lines showing the 95% confidence intervals. When you see this also, you can then break it down into little buckets to look at the hazard ratios. And below 4,000, the hazard ratio for vericiguat compared to placebo was 0.77 for cardiovascular death or heart failure hospitalization. And even below 8,000, it was 0.85 and remained significant. And only above 8,000 does the hazard ratio go above 1, but remain non-significant. So if we go to the next slide, we've done the same for cardiovascular death and heart failure hospitalization, and you can see the respective hazard ratios and confidence intervals there, showing that really for cardiovascular death, below 8,000, it is statistically significant. And the same for heart failure hospitalization. Now, we've also adjusted for important variables such as the MAGIC risk score and even an internally derived Victoria risk score to adjust for any of those confounding variables that we thought would be playing a role in this in terms of either the NT-proBNP levels or the outcomes or both. And so we think that these are statistically robust and certainly have a lot more meaning than the unfiltered quartiles. So if we go to the next slide, this is really a summary of what we found. When we looked at patients below an NT-proBNP of less than 8,000 picograms per mil, which is approximately 86% of the Victoria population, so a large percent, the treatment effect of vericiguat compared to placebo was really evident, and then even amplified further if they had a lower NT-proBNP of less than 4,000, which really matches the DAPA or emperor types of patients. That applies to about 65% of the Victoria population. So when we looked at the individual endpoints, we could even see that the individual endpoints met their statistical significance below 8,000. And overall, the overall trial effect was a hazard ratio of 0.90, and the patients less than 8,000 really may have enhanced benefit with the vericiguat compared to placebo. So Dr. O'Connor, I'll hand it back to you for more dialogue. Dr. O'Connor, I think you may be muted.
Justin, thank you. That was a terrific presentation and really stimulates a lot of ideas and thoughts about not only clinical trial design for the future, but also potential patient care. So I'd like Dr. Cunningham to provide the first commentary on this paper, as he did in his editorial. And by the way, both the paper and the editorial should be linked in the chat.
Great, thanks so much, Dr. O'Connor and the JACC-HF team for inviting me today. And congratulations to you and Dr. Ezekowitz and Dr. Armstrong on the publication of Victoria in this very important sub-analysis. As you just heard, there's a very statistically robust interaction between the baseline NT-proBNP and the treatment effect of vericiguat here for the primary endpoint, with patients with the lower baseline NT-proBNP benefiting more from vericiguat. So similar to the relative risk reduction seen in trials of ARNI and SGLT2 inhibition in HFrEF, whereas those with the higher NT-proBNP values basically had a neutral benefit from randomized therapy with vericiguat. Clearly, the analysis is well done and very robust. It holds up by quartiles, by continuous log-transformed NT-proBNP, and by the data-derived cut points used in the paper, and it's independent of other covariates. So I think the question is, what does it mean, both in terms of mechanism, scientifically, and then also in terms of the care of patients? And those are really my couple of questions for Dr. Armstrong and Dr. Ezekowitz. So first, what do you think about the mechanism? Why would we see this? I have a couple of ideas. One would be statistical. In time to first endpoint design in this very high-risk patient group, and maybe the high NT-proBNP patients got hospitalized so quickly, there was no time for the drug to work, whereas the lower NT-proBNP patients had more time to benefit before having an event. Perhaps looking at longer follow-up or recurrent events analysis might be able to sort that out a little bit. The other potential mechanism could be biological. We know that the drug works by increasing cyclic GMP and cyclic GMP signaling, but perhaps in the high NT-proBNP, folks who already have high natriuretic peptide signaling, their cyclic GMP is already so high, they benefit less from vericiguat. It would be interesting if there was any urinary cyclic GMP levels at baseline to try to sort that out. My second question is about how clinicians and patients can utilize NT-proBNP to prioritize treatments in HFrEF. As we all know, there's a lot of options now. Based on the entry criteria, it would seem reasonable to target patients with recent worsening heart failure or higher NT-proBNP for vericiguat, since that was the randomized population in the trial. But on the other hand, this analysis says, well, not too high with the NT-proBNP. So I'd value your thoughts on how we as physicians can utilize NT-proBNP to make the right decisions for our patients. Thanks so much for having me, and congratulations.
Well, Justin and Paul, you can split those up, mechanism, and then how should clinicians use this information?
Well, Chris, first let me compliment Dr. Cunningham on his editorial. get something more out of it every time I read it. I reread it this morning, and it's uncanny because some of his deliberations were, of course, in our minds in January of this year when we sat down and looked at this data. A couple of comments to begin. First of all, the event rates, as the audience may recall, are about 2.5 to 3 times as high, both in terms of cardiovascular death and heart failure hospitalization, than the Paradigm and DAPA-HF trial. The second is that the relationship between heart failure hospitalization and death is somewhat skewed. That is to say that there's a larger proportion of patients with heart failure hospitalization than the cardiovascular death in the primary endpoint. And as Jonathan has correctly pointed out, that may have led us to finish with a median follow-up of 10.8 months. And we did speculate in the primary paper about the tail of those curves separating. And it is important to remember that about 1 out of 4 of the primary composite endpoints was in fact contributed to by cardiovascular death. To the point of the population in excess of 8,000, if you will, the sickest of the sick with that kind of natriuretic peptide, which, as Justin pointed out, has some card-carrying characteristics that would not surprise people. Were these refractory to vericiguat therapy? One question that was raised in Jonathan's editorial was, would a higher dose have achieved a better result? We did not see a better result in heart failure preserved in the Vitality study, which was just published last week in JAMA, but that doesn't necessarily apply to heart failure reduced. The second would be, of course, did the drug get delivered? And as Dr. O'Connor knows, we're keen to get access to the plasma levels and see, in fact, whether the mail got delivered in those patients, and it was, in fact, a refractory population. But I do think that the pre-specified quadrants led to this analysis that Justin's nicely pointed out, and that the continuous relationship that Cindy Westerhout and her colleagues at the Bigger Center have been able to develop gives us new insight, not only into the incredible nonlinear impact of natriuretic peptide on outcome, but also a logic and a clinically meaningful way of applying the data to patients in this very sick population, which now accounts for 1 in 4, 1 out of 5 of chronic heart failure annualized, not responding to excellent medical therapy on which these patients were on. So, Chris, those would be my opening comments, and I look forward to the rest of the discussion.
Thank you, Paul. Those are excellent and really frame things up. Justin, would you like to respond to Dr. Cunningham?
Yeah, I think much has been said. I think one of the questions we're always worried about is it's statistical, and I think we've done a very good job of really eliminating some of the potential pitfalls one could look at in terms of the statistical considerations. But I do think the biologic one is a very fascinating one, because I don't think we know a lot about individuals with extremely high NT-proBNP levels that are in the 8, 10,000, 30,000 range. And this is one of the few trials that has had those patients in enrolling into a clinical trial. So when we start to look at the community, and we do reference it in the manuscript, is in the community there are much higher levels than we've seen in the most recent clinical trials. And so, are we fooling ourselves by not enrolling those patients into clinical trials and then utilizing those therapies above and beyond what they may be having an effect? And I think that's a real question we have to think about from a biologic perspective. And you raised one about the guanylate cyclase activity, which is a real one, or other neuroendocrine pathways that may be more activated in those patients than others, or even a blunting of the responsiveness to NT-proBNP so they continue to produce more, to be more active. I think one of the interesting parts we looked at and we thought, well, this is just all end-stage people who may not have any response to anything. But even from the time for diagnosis and some other key characteristics, there weren't those markers necessarily, coming through 100%. So I think we have to be, careful with our assumptions. And it's an area where, in searching the literature, we have not done a good job of describing the very high NT-proBNP level patients. So maybe I'll leave it with that comment.
So let me now ask my associate editors. We'll start with Deputy Associate Editor Joe Rogers to ask questions. We'll have the AEs ask questions, and I know there's questions in the chat, and Dr. Fuzak will bring those up. Joe?
Thanks, Chris. I appreciate it, and congratulations to the authors of this paper and the investigators of the trial. I think it's really an important study, and I would also extend my my appreciation to Dr. Cunningham, who I thought wrote an outstanding editorial that was really helped frame up, I think, some of the questions that we should be asking about this data. I think one of the things that intrigued me, and I'll look at this from a clinical perspective, which I often do, Chris, as you know, is I think that this allows us to begin thinking a little bit more about kind of a personalized approach to the delivery of care. And as I look at this data, I think this would influence my choice of patients in whom I might want to use the therapy. And I might, until we've got a little more data and a little deeper understanding, may try to avoid using the drug in patients with remarkably high NT-proBNP levels. The question that I had for Justin and Paul is really if you have any insights for us about changes in natriuretic peptide levels during the conduct of the trial that might provide some incremental insight about this this observation that was obtained in people who had just a baseline NT-proBNP.
So maybe I'll take a first stab. Thanks, Joe. I appreciate those comments, and I'll take a first stab, and then Paul, you may want to weigh in. So you're asking the bang-on right question about the sequential NT-proBNPs, and one of our colleagues, Dr. Adrian Boers, is working on that data as part of the Victoria trial to really look at those patients with a subsequent 4 or 8 month NT-proBNP. So what happened to those? And we recently presented the initial presentation at the Canadian Cardiovascular Society meeting about a week ago. I think it was about a week ago, which really showed that vericiguat does lower NT-proBNP compared to placebo. That was finding number one. And finding number two was there was a relationship between the change in NT-proBNP and clinical outcomes, not a surprise. And the third part, using a landmark analysis, was there was not the same association of vericiguat and placebo if that change happened. So it doesn't seem to be dependent on that effect. A fuller manuscript is going to dive into these in a lot more detail. And I think we're really interested and intrigued because there's even one more tiny piece of really fascinating information is the NT-proBNPs or BNPs between screening and randomization, which I think are remarkably interesting, but I will have to wait for the full manuscript for that, Joe. And Paul, maybe other comments from you.
I think I'll leave it at that. I think we have a lot more to learn, and we're working on it hard.
Maria Rosa, you're never shy.
So first of all, I would like to give my heartfelt congratulations to Drs. Armstrong and Ezekowitz, as well as Dr. Cunningham. I'd like to ask a question of the investigators. When you showed the characteristics of the patients according to quartiles of NT-proBNP, I couldn't help but notice that the patients with NT-proBNP above 8,000 were also those that had the lowest eGFR. So the question is it the heart failure that is too severe to see an effect, or is the cardiorenal syndrome that is too severe to see an effect? Because clinically, we see that patients that develop renal dysfunction, even independent of their heart failure, that have CKD, they have disproportionately high NT-proBNP level for the severity of their heart failure.
Maybe I'll start and then Paul jump in. Thanks for the comment, Maria Rosa. I think The key thing that we wanted to adjust for and look at was, in fact, renal function because of its effects on NT-proBNP directly, as well as the relationship to clinical outcomes for those with a lower eGFR. And so we did use a number of adjustment techniques to try to accommodate for that. It's never perfect, of course, as you know, and I think one of the questions that will be remaining for us is if there's the non-cardiovascular, non-heart failure hospitalizations were really amplified. And we didn't see a signal in that population. And we did try to do all the different ways to account for different eGFRs. But you raise a good point about perhaps there are other things playing a role, and with a longer follow-up, would that have played a different role, or with the drug, is the drug as effective or less effective in this population? That's a subject for another analysis that is ongoing, to look at the effects in across the spectrum of renal function with vericiguat versus placebo in Victoria. Because as you said, it's one of our key things we look at in clinical practice. So we'd really like to know how that plays out in terms of a clinical trial effect.
Thank you.
Yeah, we have a manuscript that's soon going forward, and it looks as though across GFR, the relationship between vericiguat and placebo is unperturbed. But there's no question, as you point out, that above 8,000, there are a variety of factors that affect outcome. And I think it's important to recognize that in these subpopulations, patients move from one quadrant to another, and it's not static. But as best we can tell from the renal data, that treatment effect relationship to placebo stays pretty much the same across the spectrum that we've seen.
Thank you.
Great. We're going to ask Dr. Greenberg, who was one of the leading investigators from the trial, and Barry, in addition to your questions, I'd like you to also comment on, you can have patients who are just too sick to benefit from a drug therapy. I think we could even probably make that argument in the ACE inhibitors, although they went pretty far down the road in class 4s. But Barry?
Yeah, no, thanks, Chris, very much. And my compliments also to the Victoria investigators, Paul and Justin in particular, and Jonathan for a wonderful review. I found this manuscript to be one of the most intriguing secondary analyses of a clinical trial that I've seen in quite a while. Many of the issues have already been brought up, but the one that Chris raises is one that really got to me, having been involved in clinical trials for many years now. If we look back, the enrollment into these clinical trials usually focused on patients with the most severe disease. And only later on did we go down to those patients with milder levels of condition. If you look at the development of the ACE inhibitors that Dr. O'Connor just mentioned, the initial study looked at very sick patients in the consensus trial. Most of those patients were class 4, and it showed a substantial reduction in risk with the ACE inhibitors. And then that was followed up with studies in milder heart failure. Same is true with the MRAs, the RAL study looking at sicker patients, and then subsequent studies looking at patients that are less severely affected with heart failure. So the question comes up whether or not we found a drug here that may be more beneficial excuse me, in those patients with milder degrees of heart failure, and the drug ought to be preferentially used in that population. The actual risk reduction, the reduction in the hazard ratio, is quite substantial in those first 3 quartiles, and makes it a very appealing agent. I think that more investigation is needed, and I'd be curious to get comment back from Paul and Justin about this. In those patients with higher levels of N-terminal proBNP, whether or not the drug should be used in those patients or not, whether we have enough data. I personally would not conclude that yet. I think more analysis needs to be done. And then finally, one brief comment about risk assessment in clinical trial populations. I think this is an area that's been overlooked, and we end up firstly getting a somewhat truncated population in clinical trials because of the whole host of exclusion criteria that we have, so that we end up with a very sometimes unrepresentative population. This population looks like it's a little bit more representative with the higher risk, but I do wonder whether or not there are better ways of risk assessment in clinical trial populations, both to help with the efficiency of the trial and also for understanding the results.
So, Chris, maybe I'll respond to Barry's perceptive comments. And of course, as he and I remember in the consensus days and in those early trials, the background medical therapy, of course, was pretty lean. And as we now look at the cornucopia and spectrum of medicines that form the platform, triple therapy in the Victoria trial was already in play, and device use was over 30%. So the ability to make a difference is challenging. But there's no question, and I think, again, Jonathan's editorial brought this out, if we'd gone head-to-head with a lower risk population, based on the data that you've seen in the quadrants and the data Justin's just presented, it's highly likely that it would look pretty good. I would also say, of course, that this drug is very safe, right? Once a day, and no renal or potassium issues, and no need for laboratory monitoring. So I think, coming back to Dr. Rogers' point, he's not sure he would use it in a patient with a peptide over 8,000. I guess the question would be, well, what would you use in that population? It's a tough population. So I think we have more to learn. I think Adrian Hernandez is working hard on getting out our prognostic model that's been alluded to here. So I hope we can contribute more to better phenotyping of the heart failure population using some of the laboratory parameters as well, Barry.
Let's Luther, you're on the board here. What as a young clinical trialist and investigator, how do you view these results?
Well, thank you, Chris, and congratulations to the investigators. It's tremendous analysis. I think that I agree with a lot of the comments that have been made. I think looking forward at, for instance, regulatory review and ultimate incorporation and integration in clinical practice, typically we've relied on NYHA classification in guidelines, in FDA labels, for instance, but we've never had a label that's incorporated an NT-proBNP level, and guidelines have really not incorporated that, at least at a high level, of recommending for or against a therapy at a given NT-proBNP level. So do you think that the future of heart failure clinical care will be guided by this as a metric of risk rather than more physician-assigned NYHA classification, or is there another metric of risk that should be used to kind of allocate therapies?
Chris, maybe I'll start with this one, and I'm delighted that you brought forward the functional classification. You may be aware that there is an analysis suggesting that there is a statistical interaction on treatment effect with the suggestion that 3/4s do not get the same benefit as 2s in both Paradigm and DAPA-HF, and that there's a higher proportion of patients with 3s and a few 4s in the Victoria trial. So it's fascinating. That's a fascinating question around the functional class, and it does seem to differentiate the population that's under study. I think you can make a good argument and I believe that Justin has made it in this paper, that if you're wanting, the natriuretic peptides will be available in these patients, and one would, I think, wonder about the value of using it above 8,000, but in a desperate situation, it might be worthwhile. So I think taking the 8,000 cut and, of course, enriching it as you go lower is always the case, but that's true with any medicine that we use. So I think it's a realistic question, and something from a regulatory point of view that doubtless is going to be on the table.
Dr. Fuzat, we have a number of questions in the chat room. Would you like to summarize those for the investigators?
Sure. We have two pretty good comments, and so I'll just read them both and let you answer. One is whether there were any subgroup analyses looking at the EF of 40 to 45. I know that's been a hot topic lately. And then also, was there any clinical kidney-heart interactions based on preclinical data with vericiguat?
So the EF data is being analyzed as we speak, so I can't comment. And the second question was something about preclinical data.
Yeah, so based on the preclinical data of vericiguat that showed significant reduction in kidney injury, they were wondering if there was any kidney heart interaction, and you may also be looking at that in a separate manuscript.
We've not seen anything on that front sequentially, other than lack of deterioration. There's no signal, certainly, of worsening renal function. But the preclinical data does raise another question, which is ischemia-reperfusion, and the question of whether patients with coronary disease, which constituted 45% of this population, might have a different benefit than those without. And that's, again, a subject that we're working hard on sorting out. But the question of life cycle management and where to go next in terms of a target for vericiguat is a subject of animated discussion. But we're wondering whether coronary disease versus non-coronary disease might play a role in the future of this compound. Thanks.
Let's do a thought exercise here with the panel, and I'm going to ask the panel to function as the Cardiorenal Advisory Committee. Dr. Fuzat has to be excused because of her relationship with the United States government, FDA. But the remaining AEs and Mutha and Jonathan will be the committee. And I'm going to pose two questions. Do you think the body of evidence shown with the overall Victoria trial and what you've seen today gives an opportunity for an indication for vericiguat to be labeled to reduce the primary composite endpoint across all patients that were studied? And so I'm going to ask each individual member to vote. Dr. Greenberg?
Yeah, I would vote in favor of that, and would not be dissuaded by a post hoc analysis of the study. I might add a proviso that there's some uncertainty about the higher level of natriuretic peptides.
Dr. Maria Rosa Constanza?
I agree with Dr. Greenberg. How could I disagree with him? But I also, I know you can't transpose what we know about diuretics in patients with the cardiorenal syndrome, but that is one group where I would want to know more about whether a higher dose of the medication might be effective in that group of patients.
Dr. Rogers?
Yeah, Chris, so I will agree with Drs. Greenberg and Costanzo. I think that based on the totality of the data that you have today, that it would be reasonable to offer an approval with that caveat that Dr. Greenberg mentioned. And I think that thing that's important to remember as we look at this trial data is that there were less than 700 patients in the highest NT-proBNP group. And so I think to be really careful about extrapolating what we learned from this paper to the larger data set.
Dr. Cunningham?
I agree. I think, we wouldn't want to use the post hoc results to definitively say that the drug is not indicated in the higher NT-proBNP groups, especially as was mentioned, that group wasn't really included in any of the other definitive trials of agents, or at least I shouldn't say any of the other, but the recent ones of agents that are approved for HFrEF and frequently used for sick patients. So I think it's reasonable just to consider the drug effective in patients with symptomatic HFrEF.
Muthu?
Completely concur with everything that's been said. I think the trial demonstrated importantly that it was safe and effective in a broad range of patients, and in the bulk of patients that were well represented across that range of NT-proBNP. I think the trial met its primary endpoint and should meet that regulatory bar.
And now I'm going to ask the difficult question, which is I'm pretending I'm the representing the sponsor, let's say. I'm asking for regulatory guidance to have in the label that the drug, vericiguat, reduces cardiovascular death in patients with an NT-proBNP, let's say less than 8,000. We could say 4,000 would be even stronger, but less than 8,000. I want to ask if you would give me regulatory labeling for that statement. Dr. Greenberg.
No, I would not, based on that. It's almost the obverse of the first question, and that is, would you not give an approval for patients that have the high levels of N-terminal proBNP? I'm intrigued by the data that shows that there is a association with the N-terminal proBNP levels, but the study was not designed to look at that specifically. It was designed to look at a population, and I would not pick out subsets to use for labeling by the FDA.
Does anybody disagree with that?
No, and I also, someone already pointed it out, but I was impressed by the graphs in the manuscript that shows that the vast majority of the population was the population that benefited. I think, if you will, the greater than 8,000 were really outliers.
If the investigators had been smart enough before this design, in the designing of the trial, they would have said, okay, we'll cap. If we capped the upper boundary, which we've never done in a clinical trial of NT-pro, we've done a lower boundary entry, but not upper. They would have gotten a result that would have allowed them, I think, to consider a mortality indication.
Chris, how do you say in America, Monday morning quarterback?
Paul, I'll take the blame on that as an investigator. What are your thoughts, Paul?
Well, I think we did see with pre-specified quartiles, a pretty meaningful effect. I think that there's a difference, and both of us, having sat for 7 years on the cardiorenal advisory and also on guidelines committees, I think it could well be that the guidelines committee will provide more clinically relevant advice about the use of vericiguat than what is in the label. And I'm okay with that. But I think that straight up, the indication for cardiovascular mortality on its own is not going to wash with the regulators, but it should in the guidelines, in my view.
I think it's a really well stated, and I think you're exactly right. I think we need to be more personalized and more flexible as we go forward in thinking about our guidance to our colleagues and our patients. Any last comments? Maybe Justin, you could give us the take-home points, the 3 take-home points for the audience, for the investigators, and for our patients.
Sure. So first of all, thanks, Chris, for hosting this. I'd say the take-homes for this are that NT-proBNP values in the Victoria trial were of striking range, including some very high-risk people in the trial. The overall trial did show a reduction in the odds of cardiovascular death or heart failure hospitalization with vericiguat, and that was further enhanced for those patients less than 4,000 picograms per mil, and still enhanced less than 8,000 picograms per mil. I think those would be the key take-homes from this analysis.
That's terrific, and we'll thank our panel today. We want to thank our investigators, thank our editorial team that put this together. This has been a really fun discussion to see an excellent subgroup analysis from an important clinical trial. So I want to thank the audience and thank everyone for joining the JACC Heart Failure Virtual Journal Club. We'll be doing this every month, and we look forward to seeing you shortly. Thank you.
Thanks, everybody.
Thank you, everyone.